We're happy to have Dr. Derek Todd today, and he'll be speaking to us about monoarticular arthritis. Dr. Todd, thank you for joining us today.
Thank you. Welcome, everyone. We'll be talking about monoarthralgias and the approach to a patient with joint pain. There are no disclosures other than some reviewing activity that I do for up to date. This is Sir William Osler, who has this, who mentioned this quip, perhaps off the cuff 100 years ago, or more than 100 years ago, and set our specialty back a bit. And he's not alone, and perhaps you're not alone if it's a bit uncomfortable evaluating a patient with joint pain. The objectives for this talk are to first review the approach to patients with a single joint complaint. Obviously, that could be an entire conference series, but we will focus it, winnow it down to the important details. Then talk about probably the two most important things that you'll be looking for: septic arthritis and then microcrystalline arthritis, gout and pseudogout. And I will intersperse some case examples throughout the talk. Please remember that as rheumatologists, what's near and dear to our heart is the clinical assessment. The history, the physical examination, perhaps in no other specialty, is it true that those are still the fundamental of how we make a diagnosis? Yes, there are laboratory investigations and imaging studies that can help, but still the clinical assessment is paramount. And what does one do when assessing a patient with joint pain? Well, as rheumatologists, most of my colleagues would agree that we are really trying to distinguish between inflammatory and non-inflammatory features to a joint complaint. That's our first division on, say, the diagnostic path of trying to determine what's going on. We, of course, can't ignore anatomy. We're trying to determine if a complaint is articular or not. It could be periarticular, related to the surrounding structures. And then, is there a joint distribution for the patient who has polyarthritis or polyarthralgias, which is not the subject of this talk? And then the chronology is important. Something that comes on explosively is often addressed differently and has a different diagnostic possibilities than someone with more chronic symptoms. And then comorbidities do come into play. Patients who have diabetes, heart disease, and obesity and renal disease, you might be thinking about gout, whereas someone who has intravenous drug use should be thinking about septic arthritis more. So what is acute inflammatory monoarthritis? We'll think of it as the red hot joint. As far as the separate causes of that, we want to first rule out septic arthritis, which would be a rheumatologic and orthopedic emergency. Second, microcrystalline arthritis can present very similarly, if not identically, to an infected joint. And then there are some situations in which systemic rheumatic disease can present with a single inflamed joint. That's often the case in spondyloarthritis, like a patient with psoriatic arthritis or reactive arthritis, ankylosing spondylitis, or inflammatory bowel disease. And then rheumatoid arthritis occasionally can have a single inflamed joint, but more likely as a polyarthritis. And the patient with trauma or hemarthrosis can also have a red, warm, swollen joint. The presentation is in hours and days, not weeks. And again, please be aware of the hallmark features of something as red, warm, and painful. We worry about septic arthritis when certain joints are involved. If the knee is involved, that is worrisome because that's the most commonly affected joint from septic arthritis. Likewise, any prosthetic joint is worrisome for an infectious process. Proximal joints are less likely to be crystalline in nature. You can see pseudogout in the shoulders and the hips and only rarely gout. And then other more axial joints, again, one would be thinking about septic joint, especially in the right clinical setting, as opposed to gout or pseudogout. You, of course, want to make sure that a person with an acute inflammatory monoarthritis is indeed mono and it's arthritis. So do a complete joint exam. If you have multiple joints involved, even subtly, that may start to make you less concerned about septic arthritis, which is usually in one joint. Polyarticular septic arthritis does occur, but patients are often extremely sick from a high bacterial burden because, remember, these are hematogenous seeding of the joint. Assessing for joint diffusion is a bit beyond the scope of the talk, but basically if a joint is swollen, you worry about it's in the joint. There are ways of assessing active and passive range of motion down here. Things that are painful with both active and passive range of motion tend to involve the joint. Whereas if the person hurts when they move it, but are pretty good when you move it as the examiner, then it's less likely to be in the joint. That is more likely a periarticular process, maybe a tendinitis or a bursitis or strain of a ligament. And then you do want to look for infectious sources and you look for tophi. So if it's swollen and you have the opportunity to do so, a joint aspirate is indicated, especially if it's a red, warm, swollen knee and you're in clinic. I'm hoping that most clinicians are comfortable with aspirating a knee. You want to have appropriate size a syringe and needle. The needle is often an 18, maybe a 20 gauge needle, but I wouldn't go any thinner than that. You need a big needle because the fluid can be quite inflammatory and cellular and very slow to aspirate if you use a small needle. You want to become comfortable doing it, use universal precautions, but you don't need complete like sterile technique. You do need to be aseptic, of course. You need cleanser, lidocaine to numb up the joint, and then you want to give the anesthesia some time. And my word of advice for this is kind of go for it, especially if it's the knee. It's very difficult to cause any injury to the knee. Just avoid the quadriceps and patellar tendons. I prefer a superlateral approach, and if it's a swollen knee, you can slip behind the patella and often be quite successful, even if the person is rather large as far as body habitus. You're going to send it for a few things. You want to send it for gram stain, culture, and cell count, and often crystals. The cell count can help you determine if this is an inflammatory effusion. The distinction, though, between a sterile inflamed process or a septic process is a bit dicey. You can see gout and pseudogout, and even some rheumatoid knees get over the classically held 50,000 threshold, where people start to think septic joint. But still, anything that's getting over 100,000 should prompt you to be thinking about a septic process first. You'll see polys or PMNs in patients with both gout and with septic joints, so that's not helpful. But if you get a bland effusion, something that looks more like apple juice than pineapple juice, then you're dealing more with a non-inflammatory effusion. Something like osteoarthritis would do that. These are the types of crystals that one can see, and there are other kinds that I'm not going to be speaking about. Recognize this is the classic needle-shaped crystal of gout or monosodium urate. If this is the direction of the polarizer, the crystals are yellow when parallel to the polarizer and blue when perpendicular to the polarizer. And this is probably a classic board question even. And the opposite fluorescence, called positive birefringence, is apparent on CPPD or pseudogout. So here, this is the direction of the polarizer, and a perpendicular crystal is yellow, and it's parallel, and it's blue. These might not be something you do yourself in clinic. If you have a polarizing microscope, that's phenomenal, but if not, don't worry about it. But the lab should be reporting these. Just recognize the CPPD can be tough to see. What to do when you're waiting for the results of a culture, because culture can take 2 or 3 days to come back. And if you're in the hospital, if the patient is hospitalized, for example, you'll get a gram stain and cell count pretty quickly. You also get a crystal analysis pretty quickly. So if you have an inflammatory effusion and a negative crystal but positive gram stain, you do need to be worried about septic joint. And someone with inflammatory effusion, again, high cell count, with crystals and a negative gram stain, you're most likely dealing with just a crystal disorder, and then you can treat that accordingly. It is possible to have both happening in the same joint. It is actually not that unusual, especially with CPPD, to see crystals in someone who has a septic joint. And then if both are negative, then you have to step back and think about other diagnostic possibilities, or perhaps that the gram stain was negative and the culture is just going to show up, in a few days anyway. And that's where you may use the cell count as a distinguishing factor. 10,000 cells, maybe you hold the line and wait. 150,000 cells, that's a little more worrisome. So what does one do for therapeutically? Well, you're going to use empiric antibiotics for someone with a clear septic joint, target the crystal disease for someone with a crystal joint, and then both, if both are present, and then you could consider the antibiotics as above, but you may be able to wait it out and assess the rest of your workup. What would that include? Well, in someone where there's a concern of infection, blood cultures, you're obviously going to do your standard peripheral workup, peripheral blood workup. You could do some imaging, especially if there's a question of trauma. And then sometimes you dig a little deeper, start doing a serologic workup or hunt for other sources of infection if someone does have a septic joint. As far as risk factors for septic arthritis, patients who are on immunosuppression, including our disease-modifying anti-rheumatic drugs for rheumatic disease. Certain comorbidities are famously associated with immunosuppressed states, which I've listed here. Prosthetic joints you worry about, especially since it's less likely to have crystal arthritis in a prosthetic joint. It's not impossible, but it's less likely. Obviously, if anyone's had any recent sepsis or invasive procedures, intravenous drug users, these are coagulopathy because blood in a joint is permissive for bacteria. And then somebody who has pre-existing bad joints, like this patient with terrible rheumatoid arthritis, is more prone to having seeding of that joint. Remember, this is a hematogenous seeding from the blood. So if you get it, this patient has a septic joint, you also need to have your blood cultures and start thinking about an echo and looking for other potential sources or areas of infection. Management of this is typically inpatient antibiotics, third-generation cephalosporin and vancomycin empirically. Obviously, you can tailor this if you get a bacteria cultured out, and then especially if there's sensitivities. We're usually dealing with staph and strep as far as pathogens. There are alternatives listed here. They're not as helpful. Might be useful to have infectious disease weighing in if you're not comfortable with this. One would want to aspirate the joint daily until you can basically drain the fluid out, because this is an area where the antibiotics don't easily penetrate. You want to assess other joints and also blood cultures to make sure that there's no other infection elsewhere. And it is important to get orthopedics on board for most cases. That's especially true if there's any prosthetic joint involved. Basically, any joint other than the knee, it's very difficult to do a serial aspirate of an infected wrist or infected elbow, for example. Even if it is just the knee, if the person is relatively young, you can rip through the cartilage pretty quickly in the setting of an infection. So having orthopedics clean it out can be very helpful. And then anything that's refractory to treatments, or if there's osteomyelitis, then the orthopedist would be involved. I do want to spend the rest of the time on gout, because I think this is one area where internal medicine and medical specialties would benefit from a topic that is not otherwise covered in this course. It's important to know that, to recall that there are two basic principles in the treatment of gout. First, clinical gout results from the convergence of these two processes: chronic hyperuricemia on one hand with crystal deposition, and then the secondary inflammatory response to the crystals. Bear in mind as we go through the rest of this talk that we do not have a medication that addresses both of these things. There's nothing that affects both inflammation and uric acid, and therefore it's often a combination of therapies to appropriately treat your patient. Second principle is that there are different stages of gout. Silent hyperuricemia exists very commonly, especially in the United States, and probably exists in some of our individuals taking this course. It is not necessarily a disease state. It is associated with some health conditions, but itself is not diagnostic of gout. Then patients can enter a phase where they have intermittent acute attacks of arthritis, tendonitis, bursitis, and then there are more chronic manifestations of gout, including the arthropathy with or without tophi, and sometimes it affects the kidney and other organs too. As a reminder, uric acid is something that changes over the course of one's life. As one gets older, the uric acid tends to go up. Remember, please, though, that the uric acid itself, hyperuricemia, is not diagnostic of gout. That means somebody happens to have a high uric acid in the setting of an inflamed joint. You can't be convinced that that's a gout attack. You need to aspirate the joint. Second, a normal uric acid does not exclude the possibility of a gout attack. Patients can have a normal uric acid and tell a pretty darn good story for podagra, and gout remains on the table. So this is more just stratifying the possibility of a gout attack rather than making a diagnosis. There are many factors that affect a spot serum uric acid. Hydration status and dietary status can influence it quite a bit. Patient who's dehydrated, the uric acid will go up. Patient who's over-replete in their fluids, you can have the uric acid go down. We actually see this a lot in our dialysis patients where the uric acid is bouncing around all the time. Any acute change in renal function will affect the uric acid, and certain medications like diuretics, which have perhaps been recently started, would affect the uric acid, sometimes quite markedly. And then I think this is important, hence I italicized it, and that is that the uric acid often drops in the setting of an acute gout attack. So if you're seeing the patient in your clinic and there's a patient has podagra, and you check your uric acid and it's 7.1, which is right on the cusp of normal, you might be less impressed by it. I might see that patient as a follow-up 6-7 weeks later, the podagra is over, recheck the uric acid, it could be 9 or 10, which changes how we think about that episode. Doesn't mean it was gout, but it makes it much more likely it was gout. So the final thing about uric acid, this is perhaps our best biomarker, better than any of the other biomarkers you're going to hear about is in rheumatology talks. It's our best biomarker for targeting a value and achieving an excellent outcome. So we will, when we're using urate lowering therapy, which is a term I'll use more in this talk, we're trying to get the uric acid suppressed below 6, and if someone has tophi, really suppressed below 5. There are factors that may be unmodifiable as far as what can raise the uric acid. I won't go through every single one of these, but they're near and dear to everyone's heart. Basically, aging men have a higher risk of hyperuricemia than anyone else, but family history and certain comorbid disease states. There are modifiable things, though. Patients will often ask, what can I do to get my uric acid level down? My advice is for them to lose weight and cut out the beer if they're beer drinkers. There are other dietary things that people can do, such as maybe cut out shellfish and organ meats and red meats, heavy dairy, high fructose corn syrup, but really it's beer, even more than the other alcohols. There are some medications which may be modifiable, although we prefer to find other ways. If someone's on an important and appropriate therapy for some other disease state, we try to soldier through that and stick with those and find other treatments for the uric acid. Anything that can get the patient's weight down is likely going to help their uric acid, except perhaps the keto diet that's come into fad lately. Keto diet can cause severe hyperuricemia, just so you're aware, even in people who would normally not otherwise have it. The acute gouty arthritis, most folks are familiar with the red hot swollen joint, as I've already mentioned. The aspirate will show inflammatory fluid in those uric acid crystals, and uric acid crystal, you can then say you have a crystal proven diagnosis of gout, which puts the stamp of approval on it. The triggers are a little tricky sometimes. Maybe patients describe some sort of repetitive overuse or recent surgery. The thing I see most commonly is there's been some change in the uric acid rapidly. So patients, example again, those dialysis patients where the uric acid is bouncing up and down, or in someone where the allopurinol has been changed. And so someone messed with the allopurinol is my way of saying patients can be on sometimes high doses of allopurinol, and if someone feels like that's too much and stops it on them, or the patient's prescription runs out and the uric acid goes from 4.5 to 11 rather quickly, that can trigger an attack. It's unclear if there's any particular dietary indiscretion, although patients are often convinced that certain foods will trigger their gout attacks. What do? You treat the inflammation. In patients with acute gout, you treat the inflammation. You're less concerned about treating the uric acid at that point. Don't forget about pseudogout. I won't spend too much time on it, except to say it's very similar to gout in its presentation. It's due to chondrocalcinosis and calcium crystals, with these being the risk factors and metabolic states in which you can sometimes see it. But usually it's something that is age-related more than anything else. Uh-oh. Sorry, there we go. That's an example of chondrocalcinosis. Managing acute gout, you first want to target the inflammation. Early treatment is important. These are universal principles for inflammatory arthritis from crystals. Early treatment, it will get better on its own if you do nothing, if the patient has contraindications to everything, but that's kind of a rough way to send a patient. Rest, ice, and analgesics are often helpful. You try to avoid the orthopedist, and then you don't mess with the allopurinol if it's a gout attack, even though you kind of stick with whatever they normally are taking. Indomethacin remains the king of the NSAIDs non-gendered, the monarch of the NSAIDs for patients who can tolerate them. But obviously there's a lot of comorbidities, be it renal disease or severe hypertension or peptic ulcer disease, which make NSAIDs less of an attraction for often the inpatient. Outpatients, pretty effective. Corticosteroids, what I will often recommend is if you can convince a patient to stick a needle in the joint, especially if it's a red hot swollen knee, ankle, elbow, something like that, that's a great way to deliver the treatment. You got to be comfortable with the procedure. Another way to deliver a rapid dose of steroid is to give an intramuscular dose of methylprednisolone, then switch them over to something oral. This is my little magic formula that I shouldn't really disclose, but I did. And it's anywhere, start around 20 or 30 milligrams of prednisone, taper it by 5 to 10 milligrams every 4 days for a total of 12 to 16 days of treatment. This is not the Medrol dose pack. The Medrol dose pack is too fast and patients will rebound. Oral methylprednisolone is an option for those folks with underlying liver disease, though, who don't seem to be responding to prednisone. So that's a little trick you can pull if you need to. And then what about colchicine? I get asked about colchicine a lot. It seems nice and safe. It's a relatively safe medication in the right patient. You have to be careful in people with renal compromise and certain medication interactions. But the problem is colchicine can be quite expensive these days for reasons that are well beyond the scope of this talk. You don't need a ton, and you certainly should not dose it to the point of diarrhea. You're going to have an unhappy patient if you do that. But I will recommend anywhere from 2 or 3 times a day for 1 to 2 days, then cut it down to once or twice a day. Now, a person has to have normal renal function, or you basically have these recommendations. Now, one little trick is that this combination, probenecid colchicine 500/0.05, it's half a milligram of colchicine. This combination is dirt cheap and is not subject to the same cost craziness that colchicine is. So keep that in mind if someone is struggling to get their colchicine improved. And the probenecid is relatively non-toxic and effective. And even folks with compromised renal function can take it without toxicity. It just doesn't help their uric acid. It's a uricosuric agent. Helpful facts here then when treating acute arthritis. It's not useful to get the uric acid at that time. You can, I shouldn't say it's not useful, it's just not fully predictive. And we've already talked about some of these other things. So I want to make sure I move forward in the interest of time. So sometimes you get patients who comes in with this, like the gouch, and they clearly have a much different status of chronic hyperuricemia, where they can get an arthropathy. It can be associated with chronic kidney disease. There are questions about cardiovascular disease as an association of hyperuricemia. And so patients, we will consider urate lowering therapy in patients where they've maximized their modifiable factors as much as is reasonably possible. And then if there's evidence of tophi or gouty erosions on X-ray, if someone's having multiple recurrent attacks, or they're a high risk of attack. The 25-year-old man who comes in with uric acid at 12.5, who had his first attack of gout, boy, if they can't fix that uric acid, there's a good chance they're going to come back again quickly. And then if there's any renal involvement, we recommend urate-lowering therapy. X-rays will show these overhanging edges, often at the MTP joint, can be almost anywhere. Ultrasound and CT scan are newer modalities that are interesting. And here's a picture of like an ultrasound that has tophus. And this is a CT, dual energy CT scan, which can pick up tophus. The goal here is you're going to treat the hyperuricemia, and that's a lifelong treatment with urate lowering therapy. Again, the goal numbers are here, and almost everyone can achieve this. The reason these are the target numbers is the solubility of uric acid is about 6.8 milligrams per deciliter. So if you get from 11 to 9, you've not done your job. The patient needs to get below 6 and really below 5 if they've got a foot. Well, that's a disaster. But if they've got a bad foot or a bad tophi. There are xanthine oxidase inhibitors, allopurinol. That's our primary treatment for these patients. Febuxostat is an option. Uricosurics are not terribly effective. This isn't even on the US market anymore. I don't think it came out and had no market penetrance. And these are recombinant uricase, which is something you're going to reserve for the rheumatologist to prescribe. You don't want to lose your patient though. So if you treat them and the uric acid levels drop, they drop precipitously, you can actually cause an attack. So you're going to almost always, unless there's some good reason not to, co-prescribe some sort of anti-inflammatory, colchicine being the best. Daily colchicine for months while you're getting the patient to a normal uric acid level, a target uric acid, and maintain them there, and then peel away the colchicine. So we're not going to be able to get through all these slides. I see the time getting short, but again, allopurinol is the most effective and the safest agent. I get lots of questions about this. I can answer some later. I'll try to stick around for the question answer session even later, which I should be able to do. We're going to titrate the allopurinol, and there's no cap at 300 milligrams. You can keep going as long as the patient tolerates it without toxicity. What I do, I've put it here. You can read it through on your syllabus. Start with 100 milligrams daily and go up by 100 milligrams each month until they reach their target. Check the uric acid along the way. And once you reach the target, you just keep them there. Maintain the colchicine the whole way through, 6 to 12 months after achieving the target, and then space it out. And that's a pretty narrow pathway for patients, but if they can follow it, they do great. What happens? Why doesn't this work? Well, sometimes we underdose it. Other times patients don't take their medicine. But, rarely have we found someone who's non-responsive to allopurinol. There are toxicities, and these are reasons to switch off the drug. I have to mention the allopurinol hypersensitivity. Allopurinol itself is not typically nephrotoxic, even at high levels, unless someone experiences one of these very rare but severe hypersensitivity reactions. And these can be somewhat predicted. Patients of certain ethnic backgrounds can carry a relatively high percentage, carry this particular HLA B5801 haplotype. I check that. It's something you can order. You got to figure out how to do it in your electronic system, but check that. And if they have that, then they have a 10% or more greater chance of a severe hypersensitivity reaction. So I avoid allopurinol. And for that patient, actually, I was going to mention this, allopurinol doesn't seem to have other benefits outside of lowering uric acid. It doesn't seem to help the kidneys, which has come up recently. But for the patient who can't tolerate allopurinol, febuxostat is an option. Does carry a cardiovascular black box risk, which basically needs a conversation with the patient. For me, allopurinol remains the preferred xanthine oxidase inhibitor. It is safe in doses other than traditionally thought. And febuxostat should not be totally cast aside, but really I reserve it for patients who have hypersensitivity to allopurinol. So I'm going to get to my conclusions here, and there were some questions. I don't think we're going to have time for them. But basically, with gout, we're trying to obtain a crystal proven diagnosis, and you treat the inflammation when someone has an attack, and then you determine if you feel like they're a patient who's a good candidate for long-term urate lowering therapy. Try not to mess with the allopurinol when a rheumatologist has carefully, this is number 6, got to put this plug in there, when a rheumatologist has carefully spent time to get them up to a target dose. And that's pretty much it. There are some case examples. I see Paul there on the screen. What do you think, Paul?
So we'll stop there, Derek,
Okay.
and we will save questions. There have been a number of questions that have been submitted, and they'll be answered during the Q&A, but we won't have time to do the audience response questions, unfortunately. Derek, thank you again, and we'll see you a little later during the Q&A. Thank you.